I'm Peter Black. I'm a urologic oncologist and professor in the Department of Urologic Sciences at the University of British Columbia. Yeah, I think the NIMBUS trial adds some very important information to this question. We've had various guidelines over the past several years on how best to manage BC shortage, which has hit many areas around the world. I think the NIMBUS trial really tells us that we should not leave out doses, so we should not decrease the frequency of dosing, but instead should use other measures that have been tested in other trials, such as reduced dose, so you can go down to 1/3 dose, for example, as long as you're able to give then the open vial of BCG to 3 different patients. It only makes sense if you can treat 3 patients at the same time. So definitely reduction in the dose, but not in the frequency of dosing, would be the take-home message from this trial. Yeah, I think that the value of a high quality TURBT tends to be underestimated a little bit. Specifically in the NIMBUS trial, we see really outstanding results with respect to recurrence-free survival at 1 and 2 years. And we don't know exactly why it's so much better in this trial than in prior trials. And in particular, I'm referring to the control arm that gets the standard dosing BCG. But Professor Grimm makes the case, and I think he makes it convincingly, that the repeat TURBT is an important part of it. In other prior trials, prospective randomized trials, the quality of the TURBT wasn't controlled for, so that's a relatively unique feature of this trial that they've written that into the protocol. And so 91% of patients had a repeat TUR. We know from other trials, other even systematic reviews, that approximately half of patients with high-grade papillary tumor, so high-grade TA or high-grade T1, will have residual disease at the time of TURBT. So it certainly makes sense that that would have a big impact on the final outcome. Obviously, if you're leaving tumor behind before you even start BCG, the recurrence you would expect to be higher than if you clear it out completely. One of the big questions around intravesical BCG therapy has always been the mechanism of action. And I would say that as a scientific community, we're continually chipping away at our understanding of it, although it's not completely understood. There are various elements of it that are understood. And one thing that has come out over the years is that there is some biologic rationale to the dosing that we use. The dosing was arbitrary in the first place, but there's now data from various trials in animals and in patients that it does make sense to give 6 doses of induction and then 3 doses of maintenance. You see a rise in activated immune cells, T cells, for example, over the first 3 or 4 doses of induction, and then it plateaus for dose 5 and 6. You see the same with cytokine release. So from a biologic point of view, it makes sense to give the full 6 doses, and it makes sense that reducing to the NIMBUS strategy would not work as well. And the trial clearly shows that, and I think the reduction in dose frequency is simply reflecting the biology that we've come to understand over the last decade or two. Yeah, there's a lot going on in the clinical trial space around high-risk non-muscle invasive disease, patients who are BCG naive or BCG unresponsive, or the ones in between that we don't have a good name for, but BCG exposed or BCG experienced. The first trials in the BCG unresponsive highlight single agent immunotherapy, especially in some intravesical treatments, and they have some success, but they're not quite home runs, I would say. And I think the next logical step would be either combinations or also sequences. And at the same time, we're seeing, especially the immunotherapy drugs, move into the BCG exposed and even BCG naive, where you're getting a combination of BCG plus the immunotherapy, whether PD-1, PD-L1, or even CTLA-4 inhibitors. And so it'll be interesting to see. I think it's potentially a very high treatment burden for early disease. And then on the other hand, you see the excellent results in the control arm of the NIMBUS trial with BCG will make it very difficult to show an added benefit in the BCG naive setting. But I think ultimately, if not BCG naive, then BCG unresponsive, clearly combination therapy will be very interesting to explore in the future.